Hi, everyone. My name is Gustavo Velasquez, and today I'll be talking about tuberculosis for the non-ID specialist. I have no relevant financial disclosures. So today we're going to talk about diagnostic approaches for latent tuberculosis infection, or LTBI, and we'll review treatment of LTBI. And at the end, we'll also cover the diagnosis and management of active TB as well. So first, a word about tuberculosis burden. So about a quarter of the world's population is thought to be infected with tuberculosis. And in 2018, there were 10 million new cases of active tuberculosis and 1.5 million deaths. So that makes it one of the top 10 leading causes of death in the world and the leading cause of death from a single infectious agent, actually even more than HIV/AIDS. And it's unfortunately also the leading cause of death among people living with HIV/AIDS. So huge burden. Here you can see just visually the incidence rates for active tuberculosis in 2018. I just want to point you to actually the second lightest green, the 10 to 99 incidence per 100,000 population per year. So actually here in the US, our CDC guidelines state that anybody from a country that has greater than 20 per 100,000 incidents per year is a high risk patient in terms of having acquired TB disease while living there. Now, just moving on to the clinical scenario. So we'll start off with latent tuberculosis. And first, just a word about definition. So what is latent TB? I think we're all used to what we learned in med school, which is that TB lives in people in two different ways, either latent or active. The reality in non-human primate studies and now more in clinical human studies is that actually there is a little bit of a spectrum here where there is such a thing as subclinical TB. And what mediates the balance between these two conditions is actually our immune system and pro-inflammatory immune responses that either way, if tipped, the balance can become pathologic in either way. So to move on about diagnosis for latent TB infection, so skin testing or TST, tuberculin skin testing, is really what we've had the longest. This is done with a purified protein derivative, or PPD, solution that contains multiple antigens, and it's injected intradermally, usually in the forearm. The thought behind this test is that inflammatory cells that are sensitized already to TB will migrate to the site and they'll cause the delayed type hypersensitivity reaction, or a type 4 reaction. And that's why we read the TST after 48 to 72 hours to see if there's a zone of induration. Now, there's no gold standard for diagnosing latent TB infection, so the sensitivity and specificity for TSTs is impossible to determine. But in general, we consider a positive reaction to be indicative of current infection. Now, an important caveat there is that there are false negatives, and even in active disease, you can get a false negative on a TST. And so it's not a great diagnostic aid for active disease. Who should receive TSTs? So anybody who's at high risk that you can see there on the slide. I'll just mention in red, I highlighted healthcare workers because just last year, the CDC changed the recommendations for healthcare workers. I think we're all used to seeing or to having had TSTs planted every year. Now the CDC's approach is a lot more based on the individual risk characteristics for healthcare workers. And in general, people will still get the TSTs at pre-employment, but then afterwards, people are less likely to get the annual PPD planted. What constitutes a positive test? So in anybody who's at very high risk because they're immunocompromised or close contacts of TB cases, then the cutoff is at 5 millimeters or higher. Anybody like a healthcare worker, mycobacterial lab worker, or somebody from a high incidence country would be 10 millimeters. And people who are at low risk would be 15 millimeters. At the bottom, it's a little tongue in cheek, but 0 millimeters, as in you don't need to do a TST to treat them, would be immunocompromised, high risk, close contacts. So that patient population is at such high risk of developing TB if they're a close contact with somebody with known active TB that they would just be treated regardless of TST results. And so this is from the guidelines that were published in Clinical Infectious Diseases in 2017. And on the y-axis is increasing risk of infection. On the x-axis is increasing risk of developing tuberculosis if infected. And I'll just highlight what I mentioned earlier, that immigrants from high burden countries, from countries with a greater than 20 per 100,000 incidents would be considered to be at high risk of having infection with TB. And what the chart shows in the yellow, red, and blue areas is what the cutoffs are that we already discussed. But basically, depending on your risk of infection and developing tuberculosis, what your risk would be for being classified as positive and therefore needing to be treated. So a word about BCG. So BCG is actually Mycobacterium bovis BCG. It's a type of strain of Mycobacterium that was developed for vaccination. And this live vaccine can lead to a positive test. The pattern of positivity for it on a TST depends a little bit on the administration schedule. Most countries will administer it in infancy, if they do administer it. But this kind of quote unquote false positivity because of BCG vaccine is considered to be low. And in the US, most positive TSTs are thought to represent infection even in vaccinated individuals. Now, that said, there is another test for latent TB infection, and that's the interferon gamma release assay, or IGRA. So this is a blood test. And what it measures is the memory response to TB and in the positive control Mycobacterium avium antigens. And what it assays is stimulation of lymphocytes in the blood to produce interferon. And so the thought here is that only individuals who've been sensitized, i.e. exposed to TB, will produce interferon gamma to TB antigens. And there's two commercially available tests for two formats of this test. The ELISpot test is commonly known as the T-spot test, and the ELISA test is the QuantiFERON TB Gold. These IGRAs will use, as I mentioned, antigens that are found in tuberculosis. And an important thing to note is that they do not use antigens that are found or that are shared with M. bovis BCG. And so these tests will not be interfered. They will not have any interference from people that have had vaccinations. So the vaccination status will not affect the test. They're thought to have similar sensitivity and specificity to TST for diagnosis of latent TB infection. There are clear advantages to these tests because they're blood tests. They can be completed in a single visit. They're not subjective. They don't require somebody to read a zone of induration. And there's, as I mentioned, no interference from prior vaccination. The disadvantages is that they're more costly. They're not available everywhere, and sometimes logistics about when they can be drawn during the week, depending on how often these tests are sent. The current CDC recommendation is that the IGRA can be used in any setting in which a TST is used. And so when would you use IGRA over TST? So in patients who are at least 5 years old and have a likely infection with a lower intermediate risk, and LTBI is warranted, and especially if they have a history of vaccination or they're thought to be unlikely to return to have a TST read, then an IGRA would be preferred. However, TSTs, of course, are acceptable according to the guidelines if IGRAs are not available or just infeasible. Now, I made this chart, I repopulated this chart this year because actually the treatment options for LTBI have changed as of February of this year. These are the new rankings for the various treatments. Now, I'll just mention that now there's a difference between preferred and alternative regimens, and all the preferred regimens you see there include rifamycins, either rifampin or rifapentine. And the alternative regimens are now the isoniazid-based regimens that were the old gold standards, the 6 and 9 months of isoniazid. And so in the preferred regimens, we have 3-HP or 3 months of isoniazid and rifapentine weekly. And that's for anybody aged greater than 10 years. There's 4R or 4 months of the rifampin given daily, and that's been studied mainly in HIV negative populations. And then this other regimen that was really not used in the US up till now and used much more in Europe, which is 3HR, 3 months of daily isoniazid and rifampin. And this one has a conditional recommendation. But I think another important difference from prior guidelines to keep in mind is that the 6-month regimen now has a strong recommendation. The 9-month regimen is conditional for isoniazid at the bottom. The guidelines really cite just that there's not been a lot of comparative efficacy studies to show that 9 months is a lot better than 6 months. Just a word for everybody out in the audience that these are brand new guidelines. And so, it does take boards a while to catch up with new guidelines. I think that all of these, except for 3HR, would have been in the previous guidelines in just different rankings. And another point is that everybody who is being treated for LTBI needs to be evaluated for active TB first. And in general, unless people become contacts of known cases later after completing treatment, most people don't need to be retreated after they've received treatment for LTBI. So when do you perform baseline LFTs? So anybody who has liver disease, any patient who's pregnant or within 3 months postpartum, patients who have regular alcohol use, or patients who are taking medications that could be hepatotoxic. Stopping rules. So if on treatment anybody is symptomatic for drug-induced hepatitis and they have transaminases that are greater than 3 times the upper limit of normal, that would be a reason for stopping. If they have no symptoms, but their transaminases are greater than 5 times the upper limit of normal, that would be another reason to stop. And if they stop, then in general, we would not re-challenge these patients unless you consulted an expert for the LFT abnormality. So now moving on to active TB. First, I'll just mention AFB smears are the oldest test we have. This is the test that is the fastest and gives you evidence of mycobacterial disease. And in particular, people who are spreading, infectious spreaders of TB. They're also used to monitor patient response to treatment. There's some major drawbacks to AFB smear, which is first that it's the least sensitive method. You have to have at least 10,000 AFP per ml of sputum to have a positive AFB. But culture, the gold standard, needs at least 10 living TB bacilli per ml to actually become positive. The other problem, of course, with AFB smears is that it's not specific for tuberculosis. Other organisms like non-tuberculous mycobacteria, nocardia, actinomyces, et cetera, would be acid-fast as well. Mycobacterial culture is the most sensitive and specific for TB diagnosis. And its true sensitivity and specificity is difficult to calculate because actually, of all the cases that are reported in the US every year, only up to 90% of them are culture proven. So there is an entity of culture negative tuberculosis. Specificity is thought to be at least 98%, with any false positives being due to contamination in the lab. The major limitation is that they're very slow. So cultures in solid medium are kept in the lab for 60 days. Rapid culture in liquid medium is better. So the BACTIC method, it will have a positive test within a couple weeks. But also diagnosis in fluids that are other than sputum can remain problematic with any medium. So for example, pleural fluid is traditionally very difficult to isolate TB in and usually requires pleural biopsy if you're entertaining that diagnosis. So moving on to the guidelines. So if you suspect pulmonary tuberculosis, what should you do? You need to get 3 specimens for AFB smear, at least 3 ml of volume and optimally 5 to 10. In the lab for smears, concentrated specimens and fluorescence microscopy is preferred. Both, all the specimens would be cultured in both solid and liquid medium. And also there's a recommendation that nucleic acid amplification or NATs should be done on the initial respiratory specimen. And so one of the assays that is in clinical practice now, used in clinical practice, is the Gene Expert. This is a nucleic acid amplification test, very highly specific for tuberculosis and also highly sensitive for smear positive disease, lower sensitivity for smear negative disease. Actually, there's a new cartridge for the Expert that's even higher sensitivity. Also, just repeating the sample improves your sensitivity. So just to give you an example, in my hospital, to rule people out for TB, if you have 2 negative Gene Experts, that's sufficient to rule out TB in patients as opposed to having the 3 negative AFB smears. The other thing that these tests help with is detecting key resistance. So the Gene Expert will tell you not just if there's TB present, but also will tell you if there's rifampin resistance detectable. So moving on to active TB treatment, first just to mention this entity of smear negative suspected TB. So the recommendation from the CDC is to treat while you wait for culture, treat for active TB. And then once you have the culture, once you get more data, then determine what you'll do. If culture positive, then of course that's confirmed TB, so you continue. If you continue to have high suspicion with a negative culture, or if they have a therapeutic trial and they're actually responding to treatment, those patients you would continue treating. If there's no response and for some reason you've arrived at a different diagnosis and have low suspicion for TB, then you can stop. I'll mention here, and I put the quote there at the bottom for CDC, in patients who were treated empirically for TB disease and they received the initial phase, the 2 months of 4-drug therapy, that in itself will effectively treat latent TB infection in patients who are subsequently determined to have latent as opposed to active disease. And so that's the quote unquote hidden regimen, which is treating latent tuberculosis with an active disease regimen. Again, and those people who were ruled out for TB and ultimately are just thought to have latent TB, but they've managed to receive active disease TB treatment. So what is the treatment for TB pneumonia? So it's a 6-month treatment with isoniazid, rifampin for the whole 6 months. And then for the first 2 months, you get ethambutol and pyrazinamide. You also add vitamin B6 or pyridoxine for isoniazid, and that's to prevent peripheral neuropathy, which is a known side effect of isoniazid. And so after you've completed the 2 months of 4 drugs, then you take just the 2 drugs, isoniazid and rifampin, for 4 months. It is possible per the guidelines to get intermittent dosing with directly observed therapy. In practice, we generally avoid this. In the US, we generally do daily therapy, and especially if people have HIV co-infection or they have higher burden disease, so smear positive or cavitary disease. And a major consideration, again, is adherence, which is why DOT is mentioned there. Why do you need so many drugs? Why 4 drugs for TB? So TB will develop spontaneous resistance to any given drug at a particular rate. And that rate will vary from every 1 to 10,000 TB bacilli to 1 to every billion, depending on the drug. And so just to give you an idea, when people have cavitary disease, they'll have 1 billion to 100 billion organisms per gram of tissue. So it's really a numbers game. Everybody who has TB will have some TB living in their body that is actually resistant to the drugs, but it's very unlikely that they'll be resistant to all of the drugs at once. And so that is why you use 4 drugs at once to really overcome this spontaneous resistance. An important caveat there is that drug resistance can actually either be primary, which means acquired drug-resistant TB, or de novo that arises during treatment, and that would be from, as I mentioned, spontaneous resistance development. Here are some pearls for how we would modify treatment depending on issues with particular drugs. So if people are intolerant to isoniazid, you usually add pyrazinamide for the duration of treatment to replace it, which means extending it past the 2 months that it normally is given for. If somebody's intolerant to pyrazinamide, you would continue therapy with the other drugs for a total of 9 months. If somebody has rifampin resistance or they have multiple drugs that they cannot tolerate or are resistant to, then you would need an expert to essentially design a regimen that is different from the usual 4 drugs. And if somebody's co-infected with HIV, there's no particular change that's necessary in the drugs themselves, except that there are important interactions between the rifamycins, rifampin, and antiretrovirals. And so often rifabutin will be used, but it is thought to be perhaps a little less effective than rifampin. Directly observed therapy is a standard in most of the world, and the standards do vary within the US, so there's no clear guidance I could give to you about that. It does vary by state. I can mention that in Massachusetts, people will either be receiving drugs all the way down to unsupervised at home, down up to being institutionalized, even potentially against their will for receiving TB therapy. It really does vary. Practical options here would be that if you encounter somebody with TB, you can write them their initial prescriptions, but wherever you are, there will be public health clinics around you with experts that could treat the TB. And so that is something that's available to you. I think another piece as well regarding adherence or intolerance is that a lot of these drugs can be given IV, and so patients can be admitted to receive therapy as inpatients as well. Some public health considerations are that only those with active disease are thought to be transmitting, and that depends really on how much TB they have in their sputum. And so if they're smear positive, those are really the patients that transmit. And the patients that we're most worried about, TB, active TB and latent TB are both reportable diseases. And so all cases should be reported for contact tracing for active TB. And then do patients need to be isolated? So generally, if they're smear positive, they will convert to negative after 2 weeks. If they're adherent, they can go home. If they have to do a period of isolation, they can isolate at home, and their contacts will be screened. So people will generally only really need to do self-isolation for a couple of weeks in general. And who's at risk for developing TB disease? So anybody who's had increased or high-level exposures, as well as people with decreased cell-mediated immunity. So either congenital, acquired, or also there's a particular concern in HIV, which, for which the mechanism is not entirely known, but there is an increase in susceptibility, which I mentioned here. 2 pearls here are that people living with HIV are more susceptible to both primary disease and reactivation disease at all CD4 levels. That said, patients with AIDS, so low CD4 counts, are much more likely to develop extrapulmonary disease. But as your CD4 recovers, let's say somebody with living with HIV who takes antiretroviral therapy, then the type of presentation becomes more like what is expected in somebody without HIV, which is really predominantly pulmonary TB. I mentioned some of these points in HIV. So rifampin, because of drug-drug interactions in HIV with, for example, protease inhibitors, would be a reason to give rifabutin. The total timing or duration of therapy remains poorly defined as to whether patients with HIV would need 6 months or longer. And looking to the future, if there are regimens that don't contain rifamycin, those would really help treatment. And then finally, I'll just finish with multi-drug resistance, just to keep in mind that when we say those words, we mean specifically drug resistance to both isoniazid and rifampin. That's what multi-drug resistant TB means. And treatment always requires expert consultation. On a good note, there are several new drugs now coming out. So bedaquiline and pretomanid are now FDA approved. The Laminid is not approved in the US, it's approved in Europe, but it also has made it through phase 3 trials, and there's more drugs coming. Now, these are currently given only for drug-resistant TB, and their role for drug-susceptible TB is yet to be determined. So now I'll finish with a couple questions. First, which of the following are acceptable treatments for latent TB infection? So either isoniazid and B6 for 5 months daily, rifampin daily for 4 months, isoniazid and rifapentine with B6 daily for 12 weeks, all or none of the above. And so the answer there is B, rifampin daily for 4 months. And the reasons that A and C were incorrect is because isoniazid B6 daily for 5 months is insufficient. You need to give at least 6 or 9 months. And C, isoniazid and rifapentine and B6 is given weekly for 12 weeks, not daily, so only once weekly. Question 2, which of the following is true of treatment for active tuberculosis? Treatment should be initiated after sensitivity tests are available. Pregnant women should not receive isoniazid. Antibiotic choice or duration should be altered in the presence of drug resistance. Antibiotic resistance is found only in those previously treated with drugs, or all of the above. So the answer there is C. Antibiotic choice or duration should be altered in the presence of drug resistance. A was incorrect because treatment should be initiated before susceptibility tests are available. Those are the recommendations. B is incorrect because pregnant women may indeed receive isoniazid if they need to. And D was incorrect because antibiotic resistance is found not only in those previously treated, but also there is primary drug resistance, which means somebody acquired a drug-resistant strain. So with that, I'll thank you. I'll show my references, and thanks very much and good luck.